All right, this is the second video in the cardiovascular disease special population series. We were talking about the phase 1 cardiac rehab that was prescribed for the 62-year-old man after he had a heart attack and an angioplasty with stent. At the end of the last lecture, we discussed how you do their current clinical status assessment, determining their lab values, their vitals, and how to make safe decisions about whether or not it's appropriate for mobility. So let's talk about mobilization. So initially that means sitting edge of bed, going sit to stand, and standing bedside. Now there's a lot of good research to support this. Going way back, that orthostatic and gravitational stress, as soon as someone is medically stable, after an MI, prevents the expected deterioration of exercise performance. So MDs know this research, PTs need to know this research if they're in this field. It's really important. The whole medical team is working together to get these patients up and get them moving as fast as possible. Other common activities: arm and leg range of motion, self-care and toileting, and then as soon as possible, supervised ambulation. The goal is 3 to 4 times per day. You should be beginning ambulation 24 hours after 24 hours after the incident, or once the patient has been stable for 24 hours, kind of depending on what the clinical course is. So we said there is a degree of risk when we take these little mini stress tests, which is activity out of the bed after a cardiac event. Walking is the next level up in our quote-unquote graded exercise test that we're doing. So if you're trying to be safe while they're ambulating, what are you watching for? What is your surveillance focusing on based on your concern that they might not tolerate this activity? Well, you're watching for clinical symptoms of ischemia, that the oxygen requirement is exceeding the blood flow in the heart. You're pushing them too far. So chest pain and tightness, pressure, shortness of breath beyond the expected increase, palpitations, indigestion, chest burning. These would be signs that there's an imbalance between supply and demand in the heart when it comes to oxygen delivery. That level of exertion, what they're requiring of their cardiovascular and pulmonary systems, they're not capable to do at that point. So those are the clinical symptoms that you're watching for. What would you be monitoring? Absolutely heart rate. You want to see that nice increase in heart rate with the increased intensity and then a plateau. Their blood pressure response, their oxygen saturation, respiratory rate, RPE. These are the things that are giving you the feedback of how their physiology is handling what you are doing. When you are walking and you're thinking of this as your exercise prescription, what is the intensity? Typically in phase 1, this is very low intensity, like 2 to 3 METs, trying to progress them to get up to about 5 METs by discharge. The big limitation in phase 1 cardiac rehab is they have to stay at or below 70% of their predicted heart rate max. The reason for that is that when your heart is beating is when your heart is working. So at higher heart rates, there is a greater myocardial oxygen demand. So to protect the heart and stay within the limits so you're not exceeding myocardial oxygen demand, phase 1 cardiac rehab has a limit of 70% of the predicted heart rate max and or 5 METs. And that is for the first 6 weeks. This is going to go into phase 2. So the first 6 weeks of cardiac rehab, you have this cap on what you can push them. So this is another way of looking at exercise intensity by METs and really thinking about it of benefits they're getting in terms of a training aspect. At these really low METs, they're not really getting goals of increasing endurance, but they're getting all the benefits of physical activity, getting up and getting walking, Once you start getting into 3 to 4 mets, that's when you're going to start to see some endurance promotion, and then it continues from there. So this is a good chart to really tie in, the activity and the speed of the activity that you'll likely be doing in the hospital with the exercise intensity goals. Okay, so we assessed his current clinical status. We talked about what we would monitor with this patient. Let's get him up and get him moving. You have to take resting vitals, obviously. Otherwise, your exercise vitals are kind of worthless if you don't know where they started from. So before you even got him out of bed, when he is supine and at rest, these are his measurements: blood pressure, heart rate, and oxygen saturation. When you get him sitting edge of bed, you see a mild increase in blood pressure, mild increase in heart rate, and a slight drop in oxygen saturation. Is that a dangerously low level, 94%? No, it is not. Our clinical threshold that we get concerned and would stop activity would be 88 to 90%. And that relates back to that oxygen dissociation curve. We're getting into the linear phase of the curve, and patients can get into trouble quickly. You go sit to stand, and we see similar response. Slight increase in systolic blood pressure, nice little bump in heart rate. And actually, once he stood up, his oxygen saturations got a little better. Big standing upright, nice big posture. Sometimes they take some nice big full breaths. It's likely that you can see better pulmonary function once somebody actually gets up. All right, so sit to stand. Let's take him for a walk. You walk about 150 feet. We see appropriate responses in systolic blood pressure. What's happening with diastolic? Doesn't really seem like it's going up or down. Is this concerning? Absolutely not. You expect no real change in diastolic blood pressure during exercise. A nice appropriate increase in heart rate, and he's managing his oxygen saturation just fine. Get him back into a chair, and you always want to record the recovery. So at 5 minutes after sitting in a chair, what has happened to his vitals? You never ever want to induce an exercise stimulus and then plop him in the chair and walk out of the room, because the recovery shows you about his cardiovascular status as well. You want to see this nice return back to baseline. And sitting in the chair after 5 minutes, we see blood pressure is almost back to resting levels. Heart rate is almost back to resting levels, and he's sitting at a nice 98%. So this would be a successful first attempt at walking. What could have happened that would make us want to stop in this case? Diastolic pressures greater than or equal to 110 millimeters of mercury. This is an abnormal response, and there'd be a reason to terminate. If systolic blood pressure drops greater than or equal to 10 millimeters of mercury during exercise with an increased workload, this tells you the heart is not keeping up with the challenge that you're giving it. Significant ventricular or atrial arrhythmias, even if there's no signs and symptoms. I'm going to put a star in this one. We will come back to this in cardiopulm where we actually talk about interpreting rhythms. Same with the next one, second and third degree heart block. That's not something that at this point in your PT career, some of the ex-physers might be able to diagnose that, but in your PT classes, we have not yet gotten there. And then signs and symptoms of exercise intolerance. So in inpatient exercise prescription, ACSM recommendation for this type of patient would be a frequency of 2 to 4 sessions per day for the first 3 days. Does that mean a PT is going in the room 2 to 4 times a day? Likely not. Depending on family support, nursing capabilities, and patient's independence, they should be doing exercise 2 to 4 times a day with variable levels of assistance from those types of groups. Intensity, again, we are capped off by that 70% of predicted heart rate max and or 5 mets. This limitation for the first 6 weeks for cardiac rehab is kind of a favorite in the board exams. This is a nice kind of line in the sand that they will like to include in that. So I would really reinforce that idea of in early cardiac rehab for the first 6 weeks, there's going to be a limitation to intensity because you're trying to give the heart a time to heal and you don't want to overly strain it. So that kind of associates with typically an RPE less than 13 on the 6 to 20 scale. A lot of times it's described as a heart rate less than 120 beats per minute. Sometimes some clinicians like the less than heart rate at rest plus 20. That is a little bit more individualized than just that blanket 120 beats per minute. That's for the myocardial infarction. After heart surgery, they're a little bit more, the reason this is higher, so in heart surgery, you can go stay at heart rate rest plus 30. I feel like I'm not explaining this well. The difference between the two, after an MI, you can only go 20 above resting compared to after heart surgery where you can get 30 above resting, is typically with a myocardial infarction, there was damage to the heart. So there might be a greater need for healing and repair after myocardial infarction, where if someone had heart surgery, they need to repair from the surgery, but there might not have been the ischemic damage. If we think about this exercise intensity in relation to what we learned with the acute response to exercise lecture, when you increase intensity above rest, you're asking the heart to increase cardiac output. At lower exercise intensities, that increased cardiac output is met by increasing stroke volume and increasing heart rate. Once you get to higher exercise intensities and you need to continue increasing cardiac output, you have maxed out your stroke volume because you really only increase stroke volume up to about 40% of your VO2 max. So any increase in cardiac output is coming from an increase in heart rate. That's where they get really careful about these higher exercise intensities, because any increase, any little stepwise increase is going to come with a direct increase in heart rate. The time is typically about 3 to 5 minutes as tolerated, always trying to increase duration and progress the patient, which I love things like this in a slide. Increase duration progressively. That sounds so nice. How do you make that decision? How do you say to yourself, I am now going to take you to 6 minutes? Well, you guys probably already know the answer to that. You take the data in front of you and decide how they're tolerating. If they have been continually having an appropriate and adequate increase in heart rate, then they're tolerating this well and they're going fine. They've had an adequate and appropriate rise in systolic blood pressure. They're tolerating this exercise fine. There's no new dysrhythmias. There's no ST changes on EKG. They have no cardiac symptoms. If you haven't yet reached your RPE or heart rate goal, and they're having no negative indications they're not tolerating exercise, really relying heavily on the patient's subjective report in addition to those vital signs, you can take them a little further, and that's where you increase the duration progressively. Taking into account their vitals, their subjective report, trying to meet those heart rate goals, you should feel confident that you are being safe and you can keep moving your patient forward so that they get better. In general, you attempt to do about a 2-to-1 exercise to rest ratio. The ultimate goal would be to get them to do 10 to 15 minutes of continuous activity. The type is almost always walking. You do cycle ergometry in the hospital, and there's in-bed cycles, there's bedside cycles that you might be prone to use depending on your institution, your patient's preference, your preference, but a lot of the time it's getting up and getting walking. By the time they're done with phase 1, the goal is, or the expected outcome, is that you prevented the negative effects of bed rest. You have helped to prevent the deterioration of exercise tolerance that would have happened if they had just laid in bed until discharged. You've walked 5 to 10 minutes continuously around 1,000 feet 4 times a day. They were able to walk up and down a flight of stairs independently. The patients know safe heart rate and RPE limits for exercise. Big education piece here. They're independent in their, they know how to determine their own signs of exercise intolerance. Improved rate of return to ADLs, and you've optimized recovery following discharge. All right, let's look at another case. This is an 82-year-old male seen for a pre-op evaluation and education on September 21st. His symptoms are dyspnea on exertion, daily angina. He is able to inspire around 2,125 milliliters on incentive spirometry. This is the device that allows you to see how big of an inhale patients can take. We will talk about this in cardiopulm and how we do goal setting around it, but for now, just know this is a likely value to record on a pre-op. He can ambulate 450 feet independent with a wheeled walker. He has a past medical history of osteoarthritis, diabetes, and hypertension. He is scheduled to have surgery on September 28th for an aortic valve replacement and CABG. So as a reminder, this is going to be an open chest surgery. They are going to replace the aortic valve. And the CABG is when they do an arterial bypass graft, where they take a vessel from another location and they attach it to the aorta to get a new blood supply, and then attach it just beyond where the occlusion is to provide blood to all the myocardial tissue downstream of the occluded vessel. So this patient is scheduled to have this surgery, and now we're going to see him post-op day 1. I'm going to do a brief review of lines because it's really important for you to feel comfortable with what the lines are in your patient so you can defend your practice. You want to be able to be independent in making the decision, can I treat with these lines? The first is they cut into his chest. So he has 2 chest tubes to suction. So there are a couple pictures that you can see of patients who have chest tubes. They would typically be placed in the pleural cavity to remove fluid or air, maybe in the mediastinum to remove blood. The suction is to actively pull the fluid out. If it's not on suction, they rely on gravity to allow the fluid to drain out of the body. It is perfectly appropriate to treat patients who have chest tubes. Next one is an external pacemaker. So an external pacemaker has these 2 pacing pads that are on the patient's chest. They are outside of the body and they're not permanent, but they will help to control heart rate. So that should be a comfort to you that they have a pacemaker that's going to help if there's any kind of irregularities to the rhythm. So that should be a feel-good one. I feel great that they have an external pacemaker on to assist should the heart develop any kind of an arrhythmia. EKG monitors the heart rhythm, so you would be seeing a continuous readout on the monitor of what's going on with the heart rhythms. This patient has an arterial line, and you know someone has an arterial line when you look at the IV pole because the bag has this very unique presentation that it is going to be under pressure. So it's a little hard to see in this picture, but it will be surrounded by an air-filled sac that's inflated with air to squeeze the bag. And that is because an arterial line is in a vessel that's under high pressure. So if the bag with whatever material is going into the artery was not under pressure, then fluid always moves from high to low pressure. So blood would actually leave the body and go into the IV bag. So the bag has to be under pressure to drive it into the high pressure artery. This is important because if this line would get pulled out, this is an open artery. This is a high pressure artery that would cause a lot of bleeding. So this would be an emergency if this line would get pulled out. Can you treat with an artery line? Absolutely. But you want to know to look for the bag on the line. You would have already seen it in the chart when you did your thorough chart review, but you walk in the room, you see a bag under pressure, that's an art line. You want to know where that line is and inspect it before you move the patient. The Swan-Ganz catheter is the central line that goes directly into and through the heart. And most cardiac patients, after an involved cardiac surgery, will have a Swan-Ganz for at least the first 24 hours because the medical team can get tons of information on what is happening in the heart from this line. You can absolutely mobilize someone when they have a Swan-Ganz catheter, but this is a central line, so this would be a big, huge know where it is at all time. You do not want to pull in this line. This is what it looks like in real life. It's not this pretty little splay of all the ports, but rather it's typically a big mess. And we'll talk about this again if you haven't already seen it, but you can just pick that whole big rat's nest up and move it all together as one, and that is fine. You don't untangle a Swan-Ganz because it's just a huge mess. Then we have the Foley, which is obviously just a urine collection bag. You still want to be careful not to pull it out. And this person has 2 peripheral IV lines. So there's nothing on this list that prevents you from getting the patient out of bed. There's a few things that are a little red flaggy of things you really had to be careful with. The artery line and the Swan-Ganz catheter are 2 lines that you do not want to pull on or pull out. So that would take some extra caution, and maybe depending on the patient's consciousness level, cognitive status, you might need assistance when moving this patient, likely. Let's take a look at the patient's meds. So a nitrite drip, that is a nitroprusside or a smooth muscle relaxant, strong antihypertensive. ASA is aspirin, our antiplatelet. They do not want this patient clotting up after surgery. Simvastatin, I love that they always have to have statin in the name of those. It just makes it so much easier. That's his cholesterol med. Amlodipine is a calcium channel blocker. If you are not a lover of pharmacology, I strongly encourage you, instead of maybe like memorizing a laundry list of what all this stuff is, tap into what you already know. Calcium channel blocker. What is the role of calcium in a muscle contraction? Calcium is necessary for the active sites to be revealed. If you have more active sites, you have more cross bridges. If you have more cross bridges, you have a greater strength of contraction. Calcium increases contractility. So a calcium channel blocker helps to decrease contractility. Lisinopril is an ACE inhibitor. It's going to block the angiotensin, the renin-angiotensin system. So it's going to lower blood pressure and vasodilate. Metoprolol is a beta blocker. Again, really helpful. The alols are all of our beta blockers. It's going to decrease the work of the heart by blocking the beta adrenergic receptor. Again, you can tap into what you already know. You probably roll your eyes when I ask you yet again what the sympathetic nervous system does. So your alols block the sympathetic nervous system. So whatever the sympathetic nervous system does, your beta blockers reduce that. Hydralazine is a direct-acting smooth muscle relaxant, and warfarin is your anticoag. It's a vitamin K antagonist. So these drugs, there's nothing on this list that makes this patient ineligible to get them out of bed and get them moving. What are some things you want to think about with this? Beta blocker is going to, it's a beta adrenergic receptor blocker. So you would expect a potential blunted heart rate response. So whenever you're anticipating how the patient is going to respond to exercise, whenever someone's on a beta blocker, that's going to blunt that sympathetic response in the heart a little bit. So it shouldn't be alarming if it doesn't go up as much as maybe another patient would have. The labs that you have in your chart reveal show a hemoglobin hematocrit of 10.4 and 29.9. So this is a little low, right? So normal for hemoglobin would be 14 to 17, hematocrit 42 to 52. So he's definitely low. I'm sure he lost blood during the surgery. It's pretty common when they come out, they're going to be low. These aren't dangerously low levels and certainly not a reason we can't treat. White blood cells are a little elevated. So normal is 5 to 10,000. It is expected after surgery that you'd have a little bump. So these are not sky high. This does not indicate infection. It's a normal elevation following surgery. Sodium is within the normal limits. Potassium is within the normal limits. Troponin is trending down. So would you treat this patient? I hope your answer is absolutely. Get me in there. I want this job. This sounds so exciting. I wonder what's going to happen when we get him up. Let's do it. All right, so we sit on the edge of bed. Times 5 minutes, he's a min assist. We're able to transfer him sit to stand. doing great. He marched in place for 5 minutes. We did some respiratory exercises. This here is the incentive spirometer, which I'm sure many of you have seen if you've been in the hospital over the summer. This is a inspiratory device to try to get nice, big, huge breaths and fill the lungs. This is the pneumonia preventer. His vitals, heart rate was 90, blood pressure was 140/50. Then he went to sitting. His heart rate still 90, blood pressure 170/60. What's going on with his heart rate? I had mentioned heart rate response could be blunted because of the drug, but this isn't blunted. This is not changing. Does anybody know the answer? Oh, I wish I was in class right now to see the light bulbs going on some and others not so sure. Why is the heart rate not changing at all? He has an external pacer. His heart rate is being completely controlled by the pacer. So his heart rate response is going to be disconnected from the exercise demand because he's being externally paced. So that's normal and expected. Let's see. Let's look at his blood pressure went from 140 systolic to 170, and his diastolic went up by 10. That's a little surprising, but it's not enough to stop therapy. In cardiovascular patients, it says that if it gets above 110 for a diastolic pressure, you stop. It's a little concerning that it went up. That's not a completely normal response. We still do try to go to standing. Heart rate again doesn't go up. He's externally paced. His systolic blood pressure is now 130/40. This is a big deal. So the cutoff for when you stop exercise is if they drop more than 10 millimeters of mercury. And this from sitting to standing, is a 40 millimeter of mercury drop. Not to mention we see this significant drop in diastolic as well. So this would be a reason to terminate exercise at this point. You document your findings very carefully, exactly what happened at each stage to inform the medical team. Which is exactly what the therapist did. Put the patient back in bed, recorded the abnormal response, and then went and found his nurse, informed the nurse about exactly what happened during therapy. So while this wasn't a great response, we did have a gravitational stress. We got him up. We got some valuable information about how he tolerated that mobility. Over the next 2 days, the patient improved tolerance to therapy and was discharged to a phase 2 cardiac rehab center. So we discussed the 3 phases, and we've already gone into detail on phase 1. Phase 2 is the outpatient rehab piece of the cardiac rehab. We said one of the goals of phase 1 was to be having the referral to the outpatient center already ready to go so the patient can begin outpatient rehab as soon as possible. That may or may not happen that smoothly in real life, depending on the institution that you're working at. So phase 2, we're going to have about 12 weeks to work with patients, and our goals are we want to improve their functional capacity. Right? Functional capacity is like the total volume of oxygen they can bring into their body and use to make energy and perform work. We want to progress towards full resumption of ADLs, habitual and occupational activities. We're going to always be promoting risk factor modification. They'll be dealing with a counselor to handle some of the lifestyle changes. And even just saying some of the lifestyle changes really diminishes what we're asking patients to do. This is a really hard piece to change your life after an event like this. And so this whole team approach to support patients is really important. Encourage activity pacing, so taking breaks during the day so they don't get too worn out early in the day so they can't get through the day, or taking breaks during an activity, breaking up an ADL into smaller pieces. Thinking through energy conservation when they're still in this limited place, and just being aware that their body has a limitation and that it is in the process of getting better. That even though they might have to take breaks today, it doesn't mean they have to take breaks forever. So these are the goals of phase 2. What we're really going to focus on in the next video series of this lecture is this very casually mentioned improving functional capacity. How cool is that? So we will be the agents of improving functional capacity. We said functional capacity is the volume of oxygen your body can take in, your total tank that you have access to. And with training, you can absolutely increase the volume of oxygen your body is capable of taking in and using to make ATP. And if we can prescribe exercise appropriately, we can improve our patient's functional capacity. So that'll be the next video series, the how. The excitement continues. You probably can't even wait to click on the next link to get to the next video. I'll just stop right now so you can do it right away. Goodbye.